Good afternoon, everybody, and welcome to the Health Overview and Scrutiny panel. I'm Councillor Leonie Oliver, and I'm the chair of the panel. And I have to confess, this is my first time chairing, so please go easy on me. Some few bits for housekeeping. If the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lift, and please assembly at Queen Victoria's statue. In order to comply with the Guildhall's Trust Fire Marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. May I draw your attention to the fact that this meeting will be live streamed, and everyone speaking, please can you speak via the microphone so that you can be heard. Members of the press and public are also permitted to record the meeting on the understanding that neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. And please can everyone use their microphones and remember to switch them off when they have finished. I'd like to welcome new members. I think it's just me and Matt. But if we want to do some, and Susie. But if we want to do some introductions, that would be great.
Lisa Gallagher from Democratic Services.
Councillor Susie Horton.
Good afternoon, Councillor Matthew Cordy, Member for Hillsey.
Councillor, I nearly forgot my name then. It's not a good start, is it? Councillor Leslie Minahan, Hampshire County Councillor and Gosport Borough Councillor. Thank you.
Members have read the report, so presenters, please just highlight any key points or any developments that have occurred since publications. We've had apologies from Councillor Smythe, Councillor Jeffreys, Councillor Harris and Councillor Mains. And can I ask if anyone has any declarations of interest? None. Brilliant. Minutes from the previous meeting. Any corrections, anybody? No, neither was I. All good? Can I have a proposer and a seconder, please? Was I? Oh, come on in. And I'll second. Yeah, everyone can second. Perfect. Okay, so agenda 4, Dementia Community Support Review. So we've got a very extensive review here. So can I invite Steve Trembuff, please, the Deputy Director, to go through any highlights from the report, please?
Just to introduce, I've got Jess and Whistle here as well, strategic lead, who undertook the review with me. So I take the report as read. This item is the outcome of our dementia services review undertaken across Hampshire and Isle of Wight. It's part of our ongoing work programmes to review service provision due to our kind of legacy commission arrangements. So we know we have variation, and dementia services is one of those areas. Just for clarity, it doesn't include memory assessment services or our crisis services for older people. They will be taken forward during 25-26. We know this is a key area. Prevalence is going to increase significantly. And part of the review, the real focus is on the wider community pathway. We spend a lot of time around the diagnostic itself, but particularly looking at that post-diagnostic support. As you can see in the paper, the review identified variants across our 4 places, and the key areas we looked at was cognitive stimulation therapy, carer support services, dementia navigators, peer support and dementia hubs, and Admiral nurses. You can see in the paper there is no kind of unified approach. Each place has kind of bits of pieces of something different, which actually gives us a really good platform to learn from and learn from each areas and what we want to spread across. There is a couple of key recommendations in the paper, but just to be clear, there is no planned changes to current provision in Portsmouth particularly. The status quo will be remained and that will continue. Our key piece that we will take forward and has already commenced is the recommissioning of the cognitive stimulation therapy gap that we have in Hampshire and Southampton. And again, we'll be learning from Isle of Wight and Portsmouth, those services we already have in place. So that's where we're looking and prioritising. There are other high and medium kind of priority areas within the paper that were identified. particularly carer support and named worker services, and we will do a more kind of robust review in how we take them forward in 25-26. That won't be done in isolation, that will be done together with our local authorities, the Hampshire and Isle of Wight Dementia Alliance and our carers as well. That is a very quick pieces of the paper, but happy to take any questions.
Thank you for that. Can I invite Anne, Emma and Karen? That's okay. Anne and Karen. And also, if Matt, Councillor Winton, if you would like to join us at the table, then you can to chip in at any point. So Anne and Karen, if you'd like to make your deputation, that'd be wonderful.
Thank you for inviting us. Here in Portsmouth, carers feel the disease is with us minute by minute, hour by hour, day by day, night by night and year by year, for some for well over a decade. As carers, although war-weary with the disease, we have written letters, spoken out, talked to people who can make change happen, and maybe annoyed some people too. Sometimes you have to stand up and let it be known that we as carers really do matter to support this dementia journey. On reading the report, the Dementia Community Support Review, we've noticed you did listen a little bit, well, maybe a lot, but thank you. In August 2024, the dementia community lost 2 community specialist nurses. One day we had them, the next day they didn't. No impact assessment or on our vulnerable, no impact assessment on the vulnerable community, no plan in place to fill that gap at all. They were taken away without anybody knowing about it, and it was only through conversation, and they were incredibly important. So not even the commissioning body, the ICB, knew about this at the time. And we'd lost our lifelines. No other service was picking up the pieces. Nothing in place to provide the support these nurses provided. 2 community clinical nurses for the whole of Portsmouth. And here we are, 10 months later, still nothing in place. We were signposted to other areas within the city, but none have taken or replaced the service that the specialist nurses did. That clinical element is absolutely vital, we feel. We believe the specialist dementia nurses need to be at the heart of our communities, all communities across Hampshire and the Isle of Wight, and we believe local GP surgeries are the best place for these to happen. In our campaign, we have spoken to GPs and they have said that a drop of a hat, should the finances be available, they would willingly support this. Although we recognise this review encompasses Hampshire and the Isle of Wight, our questions are directed at services we have or do not have here in Portsmouth. The Dementia Community Support Review mentions OPMH, dementia, care navigators. Not once does it mention the community clinical specialist dementia nurses. And it doesn't recognise the crucial clinical element of these nursing roles and the invaluable support given to the patients, carers and extended families of the roles played by that multidisciplinary team that they were able to hold together like the glue. So therefore we're asking, can you please advise whether in collating this dementia review you acknowledge that dementia care navigators are not an equitable service to the clinical nurse?
Yes, so we do see them as different, and I think this is part of that kind of next stage of the review, identifying that, because as ever it looks like quite a complicated landscape of services, yet we've clearly still got gaps that aren't meeting that need, and I think that's where we recognise that gap, and we want to kind of work with yourselves to identify how we kind of meet that going forwards. But no, we completely appreciate the clinical specialist is very different.
Thank you. Thank you for
just come in on that and just say that in the next stage of the wider review, we will absolutely capture those functions of those clinical roles and think about what we need to do to create equity across the patch. So we would absolutely be looking at what was existing, what functions were delivered, and how we make sure that's in place.
Brilliant, thank you. And to be frank, after 7 years of caring for a loved one with dementia, personally I can signposting ourselves easily, because we really do know what there is out there. Okay, yes, new services do come up, but when a service comes and speaks to us, it smacks of telling us to suck eggs, to be truthful. Putting yourselves in the dementia carer's shoes after 6 years of caring for a loved one with complex needs, who would you contact when you're anxious about a loved one with those complex needs? Care navigator, who will signpost another service or offer educational resources, offer emotional support, signpost to home carer services, signpost to support groups, signpost for legal assistance or emotional support. So again, you have to move forward to someone else. It's not, you're crying out at that point for somebody to help you go to those services because you are exhausted. You are unable to do that because you are emotionally drained, you are broken. So the clinical nurse specialist nurse who is medically trained nurse who understands dementia can intervene. They can liaise with the GP, they can liaise with OPMH and the wider services, OTs, social services, if need be. They are a lifeline to the family, absolute lifeline. Our local knowledge is that the specialist dementia nurses are already employed in surgeries in Waterlooville and Havant, possibly. Will this valuable service be extended across Portsmouth? And which I think you've said you're investigating and seeing what there is out there, so I can understand you may have answered that question. We notice you talk of Admiral nurses working in Portsmouth, and to our carers' knowledge, there is only one employed Admiral nurse in Portsmouth, that's at QA. The only other Admiral nurses who come into the city, to our knowledge, are for the veterans, which is a very important service, but the general public do not have access to Admiral nurses in Portsmouth. A recent statement from the head of nursing for Southern Health for the BBC stated that the only way dementia nurses could work in surgeries was if they became a nurse prescriber, which is something that the clinical role could take. A specialist nurse could become a clinical prescriber, which again would really support GPs and support that time level. So it's something I think that needs investigating. As this review has only mentioned Admiral nurses, are the authors advocating a collaboration between Dementia UK, Admiral nurses, and the NHS commissioning body as a solution to withdrawal of the idea of a community specialist nurse in Portsmouth?
So I don't think we know the answer to that yet. It's the honest answer. That's what the review needs to do. There is definitely a big review that needs to happen across Admiral nurses, because when we look at it, it's very different in all different areas. So I think the point you've highlighted about there being only one at QA and then one obviously for veterans, we are aware of, but I think as part of that review we need to really map out, because there's different functions, isn't there, from Southampton to the Isle of Wight to Hampshire. And I think that's, I don't think we can second guess the answer as the honest answer, but I think we all need to come together to look at it and see what's reasonable and fair and that we can put in place to meet those functions.
Sorry, Karen, can I speak? We heard that Dementia UK will fund a project if it is going to be taken over by another body after a year. So, you know, it's worth investigating. There are things out there.
I think we definitely want to have a chat with Dementia UK about what they've put in place, because I know from the island perspective they're very engaged with that team as well. So we had the regional lead. So I think when we get to going into more detail, I think there's going to have to be a whole section on those Admiral nurses to understand what's happening, and we'll need to link with Dementia UK because it's essential. They are Dementia UK Admiral nurses. But I think understanding what that looks like across the piece is going to be key.
Thank you. Okay. Could you also clarify on the cognitive stimulation therapy sessions that last between 1.5 or 2 hours? What are the guidelines of how many people with dementia attend the CST group at any one time? We've heard some discrepancies around services. What are the guidelines for the length of the course? How many times will the CST course be available to patients with dementia during the duration of the disease? As a group of carers, we have members of our group who have been declining with the dementia over 10 years, and a 6 or 12-week CST course with an approximately 10-year deterioration of the disease, of cognitive, social, emotional, physical decline seems a drop in the ocean. If CST is used for the early stages of the disease, what is in place to support the patients and carers of the middle and late stage?
So in terms of the CST, if it's helpful, I think we'll be using the UCL handbook for CST, which is like the guidance and best practice nationally. So that's what we'll be looking at. I'd need to go back and check with that in terms of the numbers of what we would expect in that group, and we would expect any service specification to align to that, definitely. In terms of frequency, it is 14 weeks. That's what the guidance says. So I think that's what we'll be looking to commission for Southampton and Hampshire to start with, definitely, and working towards that. So that's probably the CST as it stands. We will need to just double check, obviously, what's being delivered in Portsmouth, because that's a separate contract that we're going to be looking at putting in, just make sure they align well.
The reason we're asking that question, because people are being asked to leave groups because they're less able. So dementia patients are being asked to leave a group because they're less able and can't take part in activities, although it appears to be a social group with an activity in it.
And we're unsure whether that's
Is
also
it being
under
expanded
that
to a bigger group?
So, I mean, CST is definitely, it's a stimulation therapy, so they'll be doing it, you know, with people with certain activities as per the handbook.
Yeah.
But then those wider support groups and peer support groups could be different, I think, in terms of how people come together. But we can absolutely have a look at that and just check what's happening within that part of the contract. So I can take that away as an action, absolutely, to have a look at that.
Thank you.
And
Because it's really detrimental to mental health.
And what worries me is the fact it's offered a 14-week course, and then what? You are dropped off a cliff.
And I think that's the gap bit, isn't it? So I
Yeah.
think there's the CST, and that's what the wider review is going to hopefully look at in relationship with you, to have a think about what's important to people after that point.
Yeah.
So.
Yeah, thank you. Another thing that was mentioned was around the dementia hubs. Dementia hubs, yes please, in Portsmouth, but we would need more than one because there's a north and a south of Portsmouth. But would these be run on the similar lines to the Portsmouth Carer Centre that we've got already, but specifically for the dementia community? And what would be the clinical element of that service?
And it sounds like we were repeating ourselves, so apologies for that, but I think that's what we want to work through. So how do we effectively mobilise these? What's going to be, because actually what works in Portsmouth won't work in Hampshire and vice versa. So I think that once we kind of get to that stage, that's the real kind of co-production we want to do, because I think I agree with all of your points you've made. By no means is this pathway perfect. We can see there's glaring gaps in this pathway. It's just how do we start prioritising it and working through. And I think quite often in the NHS we're dominated by data, but it doesn't actually tell us a lot. And I think hearing your views is more powerful in terms of actually telling us what's really going to make a difference. And I think that's the key bit of this review. Is not a conclusion, it's almost a starter in terms of identifying, particularly in terms of nice guidance where we have clear gaps. But actually, it's what is next and how we take that forward is key.
Thank you. That's the last one, Karen.
And the last one is around peer support. Our group of carers are living evidence that support groups can be established when a facilitated group is decided to ask less able members to leave and have our lifeline of support removed. So not only have we had it removed on the clinical nurses level, we've also had it removed on the cognitive stimulation level. So, yeah, that's why we are here fighting for the support that Portsmouth deserves.
Yeah. And my last quote, honestly, I promise, is nothing emboldens people like injustice.
Thank you. I think they're very honest accounts, and having spoken to yourself before, Anne, I think it's so important. This is a really great review. I just want to take to the floor. I don't want to take over. I've got a list of things that I want to go, but if anybody's got any questions, or if Matt, if you want to come in,
Is that okay? Yeah.
go for it.
Thank you, Chair. Thank you for coming in, ladies, and telling us about it. I think it's really important that we hear the challenges that are faced not only by patients, but by family members as well. No, we seem to have two areas. We've got the diagnosis and then we've got the support. Going back to sort of diagnosis, I was wondering if you guys could tell us a little bit more about the measures that are in place to monitor and then improve dementia diagnosis rates in our area.
Absolutely. If I'm really honest, it's kind of hearts and minds locally. Portsmouth fares well in terms of diagnosis rates across Hampshire and Isle of Wight. It's been a real kind of high flyer, and actually, to be honest, we're trying to learn from Portsmouth across some of the other areas. I think key to it is, when we speak to families, is like we just discussed, is so what? So if I get a diagnosis, what does it unlock? What does it help me with? And actually, if you've got no support offer out the other side, then actually, what's the point of the diagnosis in the first place? I think COVID also had a big impact on this, particularly when the access points are through primary care. So it's lots of. It's almost the softest side on some of the constant communications and promoting awareness, but I think some of this kind of fundamental work around the so what out the other side will also help it, and I think that will have the biggest difference, if I'm honest.
Oh, thank you, and thank you for the review as well.
Thank you. Well, particular thanks to Anne and Karen for the deputation. It was very powerful and very appropriate this week, as it's Carers Week. So a lot of people in this room know that I have a lot of lived experience around this, and I think you summed it up perfectly around the loneliness and quite frankly the fear a lot of the time of just feeling like that the answers aren't there. So thank you for that. And I think the main point I want to make on that is this notion of fragmentation versus holistic. We all know that, that's what we're aiming for. But when you're a service user, or whatever you're called in that kind of cold language, actually you can see many people and none of it fits together in a whole picture. And I think that is the crux of what we're trying to do here. So I really thank you for the report. On that, and I have a lot of experience with children's social care, but not so much on adults, and that was a really interesting read. So I guess the other final 2 points that I was interested in the disparity around the service, but also the funding routes to it, and which were in the block and which were additional bought in. And I imagine that possibly the Isle of Wight feel a little bit like Portsmouth felt with some of our children's services stuff, that when we went from CCG to ICB, that you don't want things watered down, you want things brought up to the highest level. And I guess that's the challenge, isn't it? I too think that the notion of a dementia hub is a really positive one. I've never visited one. It would be interesting to see it and to hear more about it further than the report. But going back to what Anne was saying, the gap between the cry for help and just even being heard is too long. And when you're in that space, it on a human level, it's cruel and it's painful. It leads to other problems. But even on a financial level, I reckon if you have better economies of scales by getting upstream, then actually it will pay for itself. So I obviously haven't done the financial modelling on it, but I think it's a really good report, and it very much feels like we're taking disparity and looking for a more appropriate service in each of the areas, but there is a feel around it about bringing things up rather than watering down. So I thank you for that, my comments there.
Yeah, I echo this. This is not about kind of levelling down. It's definitely looking at levelling up. I think the fragmentation is really key. I think often you'll see in the NHS we kind of add layers of services, which is down to goodwill and feeling like we're doing the right thing, but actually sometimes makes it actually harder work to access and kind of care navigators for care navigators sometimes. And I think actually that's why we're trying to not pause, but consider actually what is the key bit, because putting yet another layer on the onion is not probably helpful, but equally there is a gap. So yeah, absolutely the key work to come.
I just want to add on that point, it's not just that it's sometimes confusing, or it actually can contribute to worsening outcomes. And I think that's a really key point to put in here.
Could I ask just a timeline, please? Because you're
So
saying
a question from my house.
yeah, you're saying that we will be needing to look further in depth. What is that timeline, please?
So, give me 5 minutes. So that'll be scheduled. That'll be in this financial year. So what we're going to do is we're going to procure out for the CST for Hampshire and Southampton, but also do this deeper dive at the same time. So we'll be doing it through this financial year so that we can have some recommendations ready for the next financial year. Definitely. That's the plan. And we'll be engaging with people like the Dementia Alliance and relevant kind of co-produced groups so that we can absolutely feed into those as well.
Thank you.
Yeah, my question was going to be the timeline. You guys had the 2 dementia navigators, and then they've just gone. What are you using now?
My husband has. We were on the telly 2 weeks ago, I think it was. He's now at end stage. So yesterday, I phoned up and asked for help. Well, last week I asked for an OT to come round. Who did you ask? An OT from Portsmouth Council. Brilliant, absolutely brilliant. The key thing is I phoned and asked for it. There is nobody around that says, hey, Anne, you need more help. Maybe we need to get your bed downstairs. You know, all those things. Now, how many carers, I mean, I work for the council, so I do know pathways. Lots of pathways. But a lot of carers are older, in their 80s, and they just put up with it and don't do anything and just struggle on. And that's, for me, is the reason we're here, because we need to find a way that flags up people that are now housebound, not going out. There needs to be somebody there.
Yeah, because you withdraw within your world becomes smaller. It becomes to the point when you cannot go outside your front door. So therefore, if you're an older person in that position, unless somebody comes and says, how can I help? You're on a caseload somewhere that flags that up. You get lost. And
That's why you need just one person. One person. In a school, it's your teacher. If you love your teacher, that's the person you'll go to with a problem. If in the old days, you'd have a doctor, perhaps. Now you get texts from doctors, so you don't have a doctor. There isn't anybody. We had dementia nurses that were those people. She would be holding me now, saying, this is what we do, Anne. This is who we call. As it is, I've got lots of people coming in doing I think Karen said on the news about silos. They all come in and do their bit and go, and you're left holding this, oh my God.
And I think, therefore, that needs to take precedent in what you do, in that actually these service users had something and it was gone, literally the next day. There was no warning, and it was gone, and it was not any of your fault at all. But yet, they're the clients that are suffering. And you marry someone till death us do part, in sickness and in health and all that, and therefore there are people that are just going to just keep going and not want to ask for help. And actually it's down to us, you know, and that service was there and then it's gone, and that's criminal, absolutely criminal. So I know you say in the next financial year, but actually that needs to take priority. There are people now, if I'm reading the right bit, 2,392 people currently with dementia in Portsmouth alone, with 2 nurses. That 2 nurses, what's that supposed to do? That just seems really, really harsh. And actually you've got a lot of men and women who are stuck in their house at home. And I think that really, that timescale of a year is great, but it's long. That's long in the days that you guys have got your looking after your loved ones.
When we raised this initially way back in August, we were told there is the Remind service, there is the older person's mental health, there is the GP, there is the carer centre. But when you're at home in that critical crisis point, it is really, really hard because, as Anne said, it is the silos. Older person's mental health will come in and review the medication.
OPMH is only, you only access that if you get a GP referral back to OPMH once you've been discharged. So if the GP, for me, it's like I really need to talk to someone who understands and is medically trained in dementia and can deal with the drugs and deal with everything. And they seem to be OPMH because it's either you get a good GP or one that's into dementia or not. And if you don't, it can change your life significantly. So it's really hard. So the OPMH isn't actually there once you've been discharged unless it becomes really complicated and behaviour and all that, and then it get escalated up again. So the Remind group was 1.5 hours a week, which we look forward to, and that kept us buoyant. You know, oh yeah, we've got that to look forward to. We've got our peer group there. We all talk to each other, and it's good. And that kept us buoyant. And then they took that away.
Was away too.
You know, they said, well, you can't come anymore. You're less able. And you think, well, actually, it's a degenerative disease. He is going to get less able, you know. In education, that would never have happened. You don't exclude a child because they've got complex needs.
And let's be fair, in other illnesses, that isn't what it goes. If you have cancer, when you start to get more and more sick, it's not like we just shut the door, you know, or diabetes, you don't just shut the door. It's a constantly evolving thing, progressively essentially getting worse, therefore adding more pressure to you. If you guys walked away, pretty certain the NHS would be absolutely screwed with the fact that they'd have to then look after your loved ones.
What carers often say to each other is, I can't be ill.
Yeah.
And that is awful when you're ill and you can't be ill and you have to sort of get through it.
And we're talking of something from 26 billion spent up to 40 billion by the year 2030, I think.
Any other comments? Councillor Winnington, do you want to chip in or are you all right?
I was just going to say, so I'm not going to comment too much, but just to reiterate about what we've agreed to take forward on this. So really appreciate the report coming today, and thank you so much for it. It's very welcome. So there's 3 more steps that we're going to do regarding this report. So bringing it here today was step number 1. Step number 2 is we're going to have a meeting with Anne and Karen, with our colleagues here and a couple of officers from the council, where we can talk more about, I think, some of the more in-depth bits and pieces, and that's also going to inform, as is this today, the 3rd step, which is there's going to be a report come to Cabinet, which will give the council's formal response to this report. As this has been obviously quite a hot topic, and I speak and I have a particular interest personally because I used to be the service manager of Remind up to a couple of years ago. So, which is where the 2, for those who don't know, that's where the 2 clinical nurse specialists worked that have been referred to today, and then the 4th bit will be we will do a motion to full council, which is when all councillors will have that opportunity to have a discussion on the reports. But as I say, the report to Cabinet will be very much informed by what you'll recommend, because I understand you're going to do some recommendations today about this report, which will inform us, and then the meeting that we'll have with the people from the ICB, with Karen and Anne, and with and with myself and a couple of officers from the council. And then, as I say, because there's some granular stuff that's obviously come out there in terms of how things are now, which I think we need to address, and also one of another carer where similar things have happened that Anne's just been alluding to, which we know are more kind of operational, so they're not directly connected with this report, but it's about kind of some of the concerns that the carers have of what is going on at the moment. So the report's great for looking to the future, but there's obviously, you know, making sure that we're looking at what we can do to as a local authority, because in the end, though we don't fund any of this, because it is an NHS funded services, it's a case of we are there for our residents who are supported by these by this, and also it's about making sure that that the partnership working we do in Portsmouth continues, and the silos, which is always one of those things, is one of those things that if there are silos, we need to try and break them down, and that's what we do when we bring things to Health and Wellbeing Board. We work in Health and Care Portsmouth and all that kind of thing. So that's just to give a flavour of what it is. As I say, it's not for me to come up with any recommendations for this panel. So, but I look forward to what they are. But I'd like to thank everyone who's been here today, and especially Anne and Karen, because it's your lived experience is the most important thing, and the lived experience of your loved ones as well. And this is what we're here for in the end. And I'd like to really commend the engagement as well that Jess has given you. And I think, and I said to Anne before this meeting when we had a chat yesterday or the day before, you've really made a difference to what this report looks like, because it's that real lived experience which really informs and brings things home. So that's fantastic.
Fantastic. Just one thing I've just spotted. It says here in the Portsmouth column on page 22, or is it page 12? I'm not really sure. Page 22, I think. Under all of the funding section is that contract expiry April 2024 with a 6-month extension enacted. What's next?
So we've already enacted the extension by another 6 months, so it will be funded till the end of the year, and we just need to have a discussion with the current provider about what the potential is. But it's been extended till the end of the financial year.
Yeah, so we're
April next year.
as it stands April next year, so we're committed to the service as is will not be impacted. It's more just a contractual mechanism of how we do it. But yes, the 6 months, sorry, we should probably update to that. It's effectively 12 months.
Perfect. Anything else from the floor?
I just want to also say thank you to Karen and Anne, your lived experience, like you said, and you have my empathy, because every day you must feel like you're battling for the most basic stuff. I really get that. And then when you go to be somebody and they say, oh, you need to go somewhere else, you're just like, just don't do this to me. And then you have to explain the situation to somebody else. But I also recognise that you guys have got a really tough gig. You've got an increasing ageing population. You've got a real demand on your budget. And the fact that people still work in silos is incredulous, isn't it? Sorry. I just want to say thank you, and for listening to these people and taking on board their very valuable insight. Thank you.
So recommendations. This is the bit I was nervous about. Anything jump out that I'm happy to go with. I definitely believe the timescale needs to be, looked at but also rigid and stuck to, because otherwise these poor families are just going to get forgotten for longer as their loved ones get progressively worse. And I would say the other connections around. I mean, you look at the Hampshire and Isle of Wight, the Isle of Wight column, they seem to have it literally nipped. Like, we need to be jumping on the back of them. What are they doing so well? I mean, and yet they've got quite a big population of the elderly. So why have we got so many gaps and yet they seem to be the green flashing light of everything over there? Go on, you're going to come.
No, it's fine. It's because, so I was the Isle of Wight Commissioner that led on that, so it's a dementia strategy, and they coordinated between the council and the healthcare, so that pathway absolutely, I mean, it took 4 years to get there, but they absolutely planned that between local authority and health to start to look at having a joint strategy and kind of commissioning support functions around that.
So can that be a recommendation, that can be something that we can look at? Would anyone be in a disagreement with that? I think you've got a perfect model there that's happening over in the Isle of Wight with a very large population of elderly and a large population of those with dementia. And if they're doing it so well, why are we not copycatting when we've got quite big gaps? Anybody, any thoughts? Go on, Lizzie.
Is there a different demographic in Portsmouth that affects that success? So I don't know what the demographic is on the Isle of Wight. So I know that Portsmouth has huge areas of deprivation. Is that a barrier?
I mean, there are areas of deprivation on the island as well, definitely. There's a very significant ageing population and an influx of an ageing population. So probably in terms of when you look at the paper, the prevalence of ageing is probably higher there. But in terms of deprivation, I haven't seen it comparable, but there are absolutely wards in the top 10% and top 20% most deprived, definitely, in areas, I think. So it's not very culturally diverse, is the honest answer, on the island. But I think that doesn't mean you don't do something. I think it means you take a different approach when you do it.
Yeah, no, good. Any other comments?
Is it worth capturing the next steps rather in the recommendation?
Yes.
Like what Councillor Winnington outlined, just so that there's...
So the four stages that's going to happen next. So, oh gosh, if I get order wrong, Matt. So you're going to be meeting with service
Shall I just repeat? Yeah.
Please
So we'll be arranging a meeting. So we'll be arranging a meeting with myself, Anne and Karen, our colleagues from the ICB, and a couple of senior council officers. So that will be going on. We'll then be your recommendation you're doing today. Will inform, as will that meeting, about a cabinet report, which will then do the formal position of Portsmouth City Council on this report, on the paper, and then we will have a motion at full council, which we promised at last full council, which will reflect all of those things, all the things that have been going on. And then that will be an opportunity for effectively endorsing that position, and the opportunity for all councillors to have their say and speak on what I know is something that many councillors have a deep interest in.
Can I ask when that last council meeting, that final?
That will be in July. So it'll be July's council. So it'll be in about a month's time.
Just so I can see the...
Yeah, that's fine. Yeah.
So that bit is actually quite prompt, isn't it? We're looking at within the next 4 weeks.
Yeah.
That is going to be happening.
Yeah, and the cabinet as well will be because things can run quite concurrently now. So so the most important thing is have that meeting, that meeting with yourselves and the ICB, etc. And because that's going to inform everything else. But as I say, but we've got a timescale on that because our last council meeting until the autumn is in July, so we have to make sure we get it in then.
Can I just ask, did I hear somewhere that the money's still available for those nurses, the Rowans, or did that go? Sometime I thought somebody said that money was still there.
The ICB said that.
So in the context of planning, it's complicated because the plan moves all the time. I think what we're saying is the timescales may come across long in terms of a financial year. That doesn't mean that if particular things come up in year, we're just going to say no. There is still stuff we can do, but I guess the big ticket stuff is the stuff that we're kind of pausing on. So what we don't want to do is because seeing some of your proposals as well, that's quite a different model in terms of embedding in GPs, which if I'm honest, is tends to be the way we're going when you're talking around kind of access into healthcare. A lot of it is in primary care, and then you've got the kind of development of integrated neighbourhood teams, which don't ask me about. It's not my bag, but it's just pausing to think actually where is the best place to go there. So it's not a impossibility. It's not like the kind of the pockets away. It's just how we do it.
Susie?
I can't remember whether you said this, but it would be good if the first recommendation is thanking them for the report. I couldn't remember whether you'd said it, but I think that's a good place to start, because it is a really
Yeah,
really
it is a
interesting
very, very good report, and you did cover all aspects, so thank you for that. I do appreciate that. Pat on the back. Anything else? Anything else from anybody? No? Well, then, can I thank you all for joining us today? You're very welcome to stay, or you may depart and get back. Thank you. Agenda item 5. Can I invite Jodie to come to the hot seat, please? As of before, we've read the reviews and the report, sorry. So can you give us a brief summary and any additions to things that might have changed since? That'd be great, thank you.
Yes, thank you. I think my mic's already on, so I won't touch that. Thank you, Chair. Good afternoon, everyone. Thank you for inviting me today. As said, the report has been read, but I'll pick up some key points. So a lot of the work that we're dealing with at the moment from an internal perspective is around some cost improvements and making us a really lean organisation and fit for the future as we see the NHS developing and growing. We continue to develop and increase our clinicians in our control room. That's a big piece of work going on in that space, and that is to better direct calls where it's safe and appropriate to do so. We've also embedded the social work line again, which is something that has been resurrected, which is a great resource, and they're taking referrals from row staff and also those clinicians within the control room directly as well. So that's working very well. Another development, as we continue to work collaboratively, particularly with PHU around avoiding the emergency department and how better to share the love, if you like, and the workload. So we continue to work looking at both the pathways that we can create internally, but also those that are external to the hospital as well. We completed an audit back when the new ED opened, and we're repeating that to see, and we're developing that in conjunction with social and community teams as well as PHU and ourselves to see what questions did we miss last time, what would be better to ask our crews this time, and getting that feedback as to what is available, where there might be some gaps, and what the crews are able and not able to access. One of the other things is that around a rapid assessment and decision tool, which is called the RAD tool. It's been developed by paediatricians in PHU, and it's around looking at a safe conveyance, alternative conveyance for children. So they're not always being conveyed by an ambulance. Sometimes that can be quite scary, but also in the past, if a parent has said they're going to take their children, we haven't always had that protective governance around knowing that they actually have. What this tool has enabled us is to be able to work with parents to be able to say, on this occasion, it is safe for you to take them, if that works better, and also have that protective governance around so that we can follow up and make sure that the children are being presented at ED as it's appropriate and that they're getting follow-up care as needed. That's working really well, and we're monitoring all the time, and that sort of is ongoing as well, and we've just expanded it to a larger group of staff, so we're seeing that being expanded across the area. Demand, as we would expect for the summer, has slightly reduced, but it's still busy, and unscheduled care by its nature is fairly unpredictable, and so still can present challenges at different times. And although we have very good tools for predicting demand, as we know that sometimes it can be a little unpredictable. Really good news is around our Category 2 response times, which are stabilised, and that's really reassuring because that's
sort of some of our more sick patients that were having very extended times delay getting to them, and that's really stabilised, and we're seeing the real benefits of that around our teams in the community in Portsmouth and South East Hampshire. Our move to REAP 2 has been sustained, which is really good news as well. That shows that with demand, performance levels, staffing, has all been sustained at a really manageable level to take care of our service users that we need to do. So that's a really good sign, and the fact that that's been sustained is a really good indicator. Our operational restructure is moving on as well. We've already had our corporate restructure, and that has now progressed and is at the final stages, and our operational restructure is moving on. We're now on internal consultation on some of what's been presented to the board and agreed as what our new structure will look like. And we've had a CQC visit in the last month, so that kept us busy for a little while. But we haven't had any reports back, but particularly for Portsmouth, we had some fairly good feedback on the day, which was really nice to hear, but we haven't had the full report yet. But so yeah, and everything else continues to go, working with different teams and working collaboratively within the system to try and support where we can and come up with fresh new ideas all the time. So, but yeah, and I welcome any questions.
Thank you for that. Any questions from the floor? Go on, Matt.
Yeah, okay. You mentioned there that you managed to stabilise timings. How did you manage to do that?
So one of the key areas was that we've stopped holding and the delays that we were seeing at the hospital, and one of the graphs there shows how incredible the QA has worked to reduce the handover delays. What that's enabled us is to release our crews back out into the community, so we're getting to those patients in the right timeframes that is expected from the national targets. Yeah, thank you.
What is that time frame?
So 18 minutes for category 2, but they've increased it to around 29 minutes because a lot of the trusts across the whole country, due to lots of reasons, demand through the winter, staffing, all of those other things, as well as increased delays at hospitals across the country, was making it so difficult that those targets were made a little bit more achievable, but at the same time making sure that it was still within safe timeframes. But we're way below that now in the southeast, which is incredible work.
Leslie?
Just very quickly on that point, if the ED is brilliant, as in they don't necessarily just go into ED now, they can be diverted to various places, and it is seeing a brilliant improvement in SCAS as well, hasn't it? I'm just really interested in the parents conveying their children. How long's that been in place, and what was the driver? Was it about less ambulances being utilised in a better way, or I understand about children, but I'm really interested to hear how that's going down, and if you're seeking feedback from the parents about, if it's a positive thing they feel. Thank you.
Yeah, so it was actually driven by the paediatricians at PHU. So it was not really children for us are a fairly small part of our work, so it was never anything that we really escalated, because we always think we want to be on the safer side of caution when it comes to children. But it was actually driven by the paediatricians at PHU, which we were happy to get on board with. And I think some of it, again, as I say, was around the wellness of the children, because I think it can be quite traumatic. And also, we would take parents in the ambulance with us, so they would be left stranded with no way of getting people home. They wouldn't necessarily have all of their equipment with them for disabled children or those with special needs. So they would be able to take all of that. And what that tool has done is it's enabled us to make a much more rationalised decision around what is safe and what isn't, so that we can then work with the parents to say, actually, on this occasion, this tool's saying that it's not safe for you to convey, so I appreciate that might cause some issues, but it's worth it this time because it wouldn't be safe. Whereas on other occasions, it might be, actually, we feel really safe. The crews as well are feeding back that they feel more confident in being able to let parents take children to hospital, because they know that the governance is there. The tool has been designed to err on the side of caution, but also give them confidence that if they can say to the parents,
actually you can take them if you want to, because say an ambulance can be quite scary to children, particularly if they're using them quite frequently, and on the flip side, infrequently. So it's giving confidence to the crews, but it's also giving confidence for those conversations to happen with parents, and then they've got all of their things there. So it's such a small number that it doesn't really impact on the ambulance service as much as it might do if it was an adult group of patients, but so the numbers are small that we probably wouldn't have prompted for something like this, but we're happy to work with the hospital to do it. And as I say, the governance and the safety around it has been incredible. So really good feedback, both from the crews and from ED, the children's ED at QA.
I just think that's wonderful, and it's one of those decisions where we think, God, this is such an obvious thing we should be doing. So and especially for neurodiverse people who are familiar with their parents, their car and everything, just that another transition. So yes, so thank you.
Just as another thing as well on that, we've just I've just been introduced a new procedure around the conveyance of assistance dogs as well. So that's another area that we're looking at how we support our neurodiverse clients in the community, but also the disabled, and also helping our crews to understand how the impact that has on people. And so it's around that working. So we're constantly trying to look at what are the needs of the community and how do we adapt and support that. Thank you.
Any other questions? Everyone happy? Brilliant. Thank you, Jodie.
Thank you.
Agenda item 6, public health update. If I can invite Helen to give us a brief summary on the report. Thank you.
If okay, Chair, as well, I've also got Amanda Mackenzie, who's one of our public health principals.
Of course, the more the merrier. Welcome.
Thank you.
So we have, take it that we've read the report, and then just add any summary elements or anything that may have changed since the report was published.
Thank you, Chair. So I'll take as read. There's no specific changes, although I just wanted to pull out a couple of positive points, if that's okay. So as you will know, because we come every 6 months, public health leads a range of statutory functions in the council. But again, importantly to say, we work very much in partnership. So for those of you who are really eagle-eyed, you'll note that some of the points in the presentation are also in, and I will be back with Bernie later in the Health and Care Portsmouth presentation. So a lot of how we deliver sits within that partnership approach with Health and Care Portsmouth, working closely with our colleagues in both PCC, other directorates, but also obviously in the NHS. So the only thing that has actually changed, which fortunately didn't come in until we had forwarded the papers, is, it's a good news story, is that STIs, sexually transmitted infections, in the report it's looking improved, but I'd like to say for the first time we've actually reached green in terms of our targets, which is significant. I've been here since 2020 and we've never, in that time, we've not managed to do that. And I think it's a combination of the work that Hannah Byrne, who's our lead commissioner in sexual health, has been doing in partnership, but actually working really closely, and I don't want to appear that I'm stigmatising, but with the Navy in particular, but other parts of the community really reaching out. So testing has improved in that you can now test for sexually transmitted infections. You don't have to go into health services, and a lot of people don't like to do that, so you can actually do postal testing now. And so we're really trying to use, obviously, technology and improvements in how we deliver those services with our colleagues for Hampshire and Isle of Wight Community Foundation Trust, who deliver our sexual health services. The other two areas I just also wanted, which is all good news, because they're areas, big priority areas for us in Portsmouth, is drug and alcohol use. So we've had, and it's important to put it into a context, because nobody gets additional money at the moment from government. However, we have actually had additional funding from government for the last 2 years around our substance misuse services. So it's meant that we've been able to increase the capacity, but which has led and worked very closely with SSJ, who are our Society of St James's, who are our provider, to be innovative and do things differently, which has led us to be able to increase the uptake of services and completion of services for Portsmouth. And a really good example, which I know is something that Susie is very passionate about, is following work to needs assessment with service users, but across the city around substance use, which is, by the way, I'm saying that because it's the new terminology. We do not use substance misuse anymore, so it's substance use. But we have been able to commission and provide Project W, which is a women-only service, and it came about from it being identified that women often didn't feel safe in the traditional services. Quite often they might have been a victim of domestic abuse. There might be, and very possibly, and it does happen, that their abuser might also be receiving services. So it's a great project. It's now been running about 8 months, I think, possibly a bit longer actually, and it's a service that is open, and we've got additional days, but it's a multidisciplinary, multi-service provision, so it's not just the women can go there to get basically for their treatment for substance use, but they can also get access to sexual health services. There's a creche, but also more other services. I'm trying to think of an example, but from primary care services, but broader. And it's worked so successfully, it's been so well received, that we will be looking to do something similar for all service users, so not just women. So that's one example. The second example, and I know there is a slide, but I just wanted to use it as an opportunity to plug. And secondly, I talked about sexual health, but also, and this is partly why I brought Amanda, who manages our wellbeing service and our lead for tobacco control. We've had additional money for tobacco control that came down from government. You might have seen news coverage, which has led to us being able to increase our service offer, which is an in-house offer for us. Perhaps I should let you say it, actually, working with partners. Do you want to mention?
Yeah, thank you. It's been, so the first year we had a smaller uplift of 25% people that we needed to support in setting a quit date, and we've been able to achieve that really quite well, actually, which I'm really, really proud of. In the first year, I think it's been quite difficult for other areas to be able to do that, but because we've got an in-house service, we were able to react to the funding quite quickly and upscale our resources quite quickly. And we've been doing lots of communications activity. You might have seen It's Well Worth It campaign in the city, and encouraging residents to be the focus of that. So we've actually got some residents that have been willing to put their face to the campaign and be the voice of that and support the campaign moving forward. We did reduce our prevalence in Portsmouth from 14.1% adult smoking down to 10%. So hopefully we can continue that trend. It's becoming more difficult year on year because we're coming to smaller figures now, but it's making sure that we're supporting those that need that support the most. And we're working in partnership across the city, especially with secondary care, to support those with long-term conditions, pregnancy and mental health as well.
And pregnancy is a key important target for us, smoking pregnancy. Again, with this focus, additional money, we've been able to reduce that, and that's so important, both obviously to the mother, but also the parent, I should say now is the correct terminology, but also obviously to the unborn child. So smoking is still the most significant cause of long-term conditions and early death internationally, nationally, and obviously in the city, and has helped also with the improvement of the work we've been doing around CVD prevention. Probably use my, there's a number of improvements which I hope are noticeable in the report. So I will leave it there, but happy to take any questions, because I do also recognise there's a huge breadth of what we actually deliver, from obviously health improvement, health protection, to supporting our colleagues in healthcare.
Thank you very much. Over to the floor. Any questions?
Oh, thank you. Yeah, sure. It was really great to hear about the smoking. I'm quite passionate about that. I know that you've had some campaigns on social media and they've been really successful. Have you got any data on whether that's actually increased people taking up services to stop smoking or not?
Yeah, we have actually. But when they engage with our wellbeing service, that's one of the questions that we ask them, is where they have found out about the service, so we can record whether that has had an impact. And one of the things that we're trying to do is evolve that marketing, because after a while it becomes quite out there and quite old, and people get used to seeing it. So we want to make sure that we're getting feedback from those people who are interacting with the service, and then evolving our communications campaign as well to meet that. So the Well Worth It brand, I think, has been fantastic, but it's now getting to the point where we need to start to evolve it to capture other people as well that may not have engaged it. And it's about making it more of a social norm, that it's normal for people to be quitting and having regular quit attempts, to be able to give up entirely for life, because that's where we want people to be.
Can I ask, with regards to the smoking, is this encompassing vaping, or do you see it going forward that it's going to...
At this stage, with the additional funding, it only covers smoking. However, there's a lot of activity around vaping, especially with youth vaping. So we've seen nationally and locally quite a stark increase in young people vaping in schools, especially that so we're working in partnership across lots of different settings to get some feedback from young people, get some feedback from teachers, get some feedback from parents, so that we can understand how we can address that. There's the local activity that we can do to support, but actually there's national activity that will help eventually roll out as that will help support that. So one of the biggest things is the ban on disposable vapes that came in last Sunday. And we're hoping that will really help reduce that access to those vapes, because those are the ones that young people are using. In terms of supporting adults for vaping, that's a different message. And we do have our national Swap to Stop campaign, which is, again, additional funding. So we've been able to draw down vapes, starter kits for people that want to give up smoking. It is the most effective way we found for adults to quit smoking for that period of time, and we'll support them with behaviour change for that period of time, but it's not intended that it would go on, that they continue to vape after that. So that's why that support and behaviour change is in place at the 12 weeks to help support with that.
It is a really difficult message, which we are handling, both working with national colleagues at ASH as well as obviously locally, because it is not. So it is much safer to vape than it is to smoke. I know there is a lot of information out there and people saying that the evidence isn't there yet, but there is some evidence, and we do know, so it is an evidence-based approach. We are promoting vaping over smoking, obviously, and that is the Chief Medical Officer's view. Many of you will know Chris Whitty has quite strong views, and his view is if you smoke, don't, and if you smoke, vape.
Yeah.
If you don't smoke, don't vape, don't smoke. And vaping is not for young people, it's not for children. So it's a difficult message.
And that's the tricky bit, isn't it? Because you've got smokers that want to stop and are therefore encouraged to vape, but then you've got children that actually probably may not have smoked because it's too expensive now, but actually they've got easy access to these vapes, and then you've got, very young children walking around with these pens in their mouths, and then they're not going to be accessible for much longer either.
No. And then with the commencement of the tobacco and vapes bill, hopefully the next stages when that becomes, will help support with some of those other factors, like the packaging and the names of the non-disposable products that will still be available, but we don't want them to be branded to focus on children and young people. So hopefully, as time escalates, I think this is become a national, not just national actually, I think it's a global unintended consequence of a product that was designed to support smokers quit, and it's brought up a completely different dynamic for us to have to deal with.
although being less nice than Amanda, vapes are manufactured and marketed from the tobacco industry, so they've just found another, a bit controversial, way to target. They are illegal to sell to young people, and we work really closely with our Trade and Standards colleagues in Portsmouth, who've got have done amazing work and are often recognised regionally. We've got a lovely dog, haven't we, who goes and sniffs out, and they have had quite a few very successful raids to basically take illicit vapes. It's really difficult, but I think I want everyone to go away. There is quite a lot happening, including working with schools and head teachers around messaging. So lots of action.
Any other questions? Yep, go for it.
Just coming back on the training standards, we have the same in Gosport where we have them, even cigarettes being sold £6 a packet. We've had one that's been raided 5 times. The frustration is there lacks that ability to actually close the premises. And I think something needs to change from a legality point of view of that. In relation to the pregnant mums, are we saying that we strongly help and encourage them to vape? Is vaping better for them when they're pregnant? I mean, mentally I want to say yes, but I just, do you kind of promote vaping?
Yeah, absolutely. So the in maternity, the long-term plan has tried to, NHS long-term plan has tried to give maternity and acute a bit more responsibility for providing stop smoking interventions for pregnant people at the point of them being there, because they found out it's a lot more effective, which is great. So we work really, really closely with our public health maternity lead, Debbie Hill, and we've got tobacco dependency advisors trained up. They've actually joined our Swap to Stop campaign, so they've been drawing down some of these vapes, and they've been providing them to pregnant people, but also to their families as well. So there's been an element of support, and then they've been helping support them into our service for when the time comes that they will go into that care. So yes, absolutely, to support with that, but not for long-term use, to support them quitting smoking.
So anecdotally, are you seeing an improvement in pregnant women stopping smoking?
Yeah, the figures have reduced considerably. I have to say, for many years, smoking in pregnancy rate's been quite stubborn. It hasn't increased, but it hasn't reduced at any reasonable rate. Having this and having the long-term plan and having this service within maternity has really helped impact on that.
Can I just question, so drug-related deaths remain higher in Portsmouth than the England average? Why? Yeah.
So there are obviously multi-factors, but the main one being we are a very highly deprived city with high drug use. So there are factors. I mean, the one obvious factor is why we've seen more increased deaths locally, but nationally as well, is that the drug supply chain is now, there's a lot of synthetic drugs which are much more harmful, and if overdose, much more likely to overdose and die. So that is a factor. We're doing masses of work locally. In fact, we're working with the ambulance service now around who do carry naloxone to be able to. So what we're working with is all the emergency services, the police, but also our service providers to have naloxone. Now, people might not have heard of naloxone. It is basically, if you give, when somebody is early stages of overdose, if you give naloxone, it pretty much saves lives, and it does save lives. So we are working really closely with all of our service providers and emergency services to get naloxone, and that includes the police, to get naloxone given to individuals. It's a, what do you call it? It's a bit like, yes, it is. It's like an EpiPen, very quickly, and that's been incredibly effective. But also it's really important, like mental health, where we see those with severe mental health dying 40 years earlier than other parts of our population. They die not just because of their mental health, they die because they tend to have early onset long-term conditions. And we see that a lot of our drug users are often homeless as well, and so their health is very poor and it deteriorates. So a lot of the deaths, actually more of our deaths, and worryingly increasing in women, are due to actually long-term conditions, so just dying prematurely because of their poor health, which is a combination of obviously drug use, smoking, alcohol, but also living very complex lives, often homeless. You know, so it's a factor which I think at some point we will probably be coming back to talk to you about. We're doing some work with Andy.
So women are more.
I think it's important to put it into a context, a bit like the suicide data when you see it. We're talking small numbers. When you're talking small numbers, you cannot make any comment about statistical significance. Very small numbers, but they are increasing, mainly because of the synthetic opiates that are now being on the street. But we are also and continue to see poor health outcomes for our substance users. So, but we are seeing more women in services.
It also says that you're seeing more under 18s as well. So that is on the rise of using, quite harsh substances. Any trend, any theme as to why?
I would say it's the same themes, but obviously not with our under 18s in terms of they will have poor health outcomes, but at that stage, what we're seeing, and that's not a local issue, is, like we've talked about vaping, we are seeing younger people accessing or having access to. That's why we have a very clear, and it's a national strategy, but we have our implementation plan. We have a combating drugs board, which is a sub or working group of the Health and Wellbeing Board. It's a partnership approach where you've got all the statutory partners together. So we've got the service providers, we've got the police, we've got probation, we've got the prisons, we've got the health service, all working together. And it's actually, there's a report coming to the next Health and Wellbeing Board if you look out for the papers on this. But it's basically how do we tackle the whole problem, the broader problem, so access as well as how we treat people, working with the police to try to, and they've done really well in the South East and in Hampshire and Isle of Wight to actually stop access to drugs, because you have to actually break the chain. Lots of work going on, but it's all partnership work.
Amazing. Susie?
Thanks, Helen. A very rich report, as usual. I'm more familiar with this one. I always look for the child obesity numbers in the hope that they'll come down, but they still seem to double in primary school, which always really worries me. So 1 in 4 children, I think, by the time they leave primary school, are obese. Which is, but anyway, I've talked to you at length about that. But my main question, I think, is you gave some really good examples. I think there were 3 around getting external funding for things.
Yes.
So Project Y was one of them, and I've got great interest in that. I suppose my question is an obvious one. What happens when the funding runs out? Because
it's a good question.
It really concerns me sometimes that it's not that these things are put in place, they are, but if you think about the person, if there's a cliff edge, it's back to that whole thing about, a bit of a theme for me today, about holistic versus fragmentation. So you go, let's be honest, a lot of it is about relationships, right? So you go somewhere, you feel confident, you start making changes, and then it closes. And I guess that was the same theme, going back to the dementia stuff as well, is that actually you leave people in a really unresourceful state when you were helping them.
It is a good question, and it is a challenge for us continuously, because all public services get short-term funding. The good thing I would say in substance misuse and if we're looking at tobacco, which is 2, I think. Did I give a 3rd example of additional money? Smoking, drugs.
HDRC.
I've mentioned the HRC, is that we have got baseline funding all the time. So, yes, they've both gone up for this specific purpose with a very clear focus and targets that we have to report to government on. We continuously look to be as innovative as we can. We obviously use the funding very quickly when we get it, because we don't want to lose it. I'll give you an example. There was additional funding for obesity. It was going to be 5 years, I think, originally. We got it for a year, and then they cut it. So we had to, therefore, we did have to. So we have to be careful in our commissioning intentions and our procurements, because we can't procure for services that are longer than the period we're getting funded, but we are as innovative as we can to always look for opportunities. I have to say, Alan, I know you know Alan well, Susie. Alan, who is our public health principal, Alan Noble for substance use, is probably, and I don't want to take away from others who've been successful, but he's probably our most successful bidder for additional money, and we have managed to fund a lot of things like and including things in the healthcare. So that's what we do. We are always ready. We only procure for the timeline that we've got the money, but we always try to be as innovative as we can. And the whole point of getting additional money sometimes is to be able to pilot, test things and find out what's working. There is a slide on HDRC, Health Determinants Research, which we've now got 5 million over 5 years. And that's an example of this. We will use, and it's a partnership with the University of Portsmouth and the Hive, and we will be using, it's basically to ensure that we can bring a culture of research and evaluation into the council, but working with partners. We will use that to be sure that with the whole council make better decisions. I'm not saying don't make good decisions, I'm not saying that, but better decisions what we feel are based on a research methodology. If you know what works, you should be able to make better decisions about limited funding. We're never going to keep getting more money. So that's all we can do.
Thank you. It's great to hear about your smoking and substance use strategies. I was wondering if you could tell us a little bit more about strategies preventing obesity in children. I read in the plan there that 50% of all children in Portsmouth aren't getting an hour's exercise a day.
I might bring you in a bit, but I'm going to say firstly, obesity is probably one of the and childhood obesity in particular is one of the most complex. If you've ever seen a mind map of how obesity is tackled, you can't read it. It's impossible. It's also not, there's only so much we can do locally, and that's not an excuse because there are many national, international factors. How do the industry work with government? Advertising, there's a lot happened nationally over the years around around advertising, not putting all the chocolates by the till, that kind of thing. But locally, we do have an obesity strategy and a children's obesity strategy out of work. We do a lot because it's a combination of obviously how can we, and we've worked obviously with children's, young people's directorate closely. How can we work with schools? Because it's an incredibly difficult situation. How can we work with parents? So I suppose those that are identified through the national measurement at schools in Year R and Year 6, those who are, and this is really difficult because we do get letters of complaint from parents. They get a letter and we do try to refer into services. We do, with very limited funding, commission weight management services, but it's about how you work as a whole with the family around. And obviously also we do work with the university. We were the first place in the country to get a place, which is a evidence-based play area, and we put it's in our, as you know, in one of our most deprived areas. We're working with Sport England through our alliance locally, and we did get funding for the first year from national funding from Sport England for in Landport, and it's a project working with communities and families. So
Was it Somerstown?
it wasn't Somerstown. We're now broadening. Anyway, it was a very small. Sorry, and I should have it. It's a very small area, but they've now agreed that we can broaden that funding. Same funding, but we can broaden the area that receives support. So that's working with families around what is it that they want that will encourage increased physical uptake. You go to people and talk about going to the gym or sport, it turns people off, particularly in some of our communities. So how can we work with those communities to support it's a community-led ABCD model where it's community-led. Where can we work with them to support them to increase physical activity in their communities? So, and that's also we're working closely at the moment, which isn't in. The next time we come, we'll bring some slides on it. We've just got to, I think yesterday's the first day that Hayley Cook moved from her previous role as Head of Health and Care, Portsmouth Comms, into community development role. So she's leading, working with our team. It's a joint post with our colleagues in the ICB, and we're working with 2 communities at the moment, but it will broaden, which is, and now I'm going to ask again, my brain's not working, which is Paulsgrove and Portsea. And it's again working communities. So there's a breadth of different work, working community bottom-up approach, what will encourage you to take a more, I suppose, healthy lifestyle behaviour. So it's working with communities, working with schools, services and broader. So, and then we have to work nationally with government around trying to do things like keep fast food adverts off the telly until children have gone to bed, working with planning around reducing, which is a really difficult one because of the economic impact, fast food outlets. We do, the one thing I'm very proud of in Portsmouth is you will not see on any of the council, what do you call them, posters, thank you, any fast food. But that's not the case everywhere in the country. There will be no McDonald's or no, sorry to mention them, but or you know Kentucky Fried Chicken adverts in Portsmouth. Sorry.
The scheme that the children are being measured against, is that not seen as a bit archaic now? The BMI, is that still?
Yeah.
Yeah.
It is a evidence-based national system, so we don't have any choice. It's a mandatory. It's one of our 6 you might be surprised because it's odd, the choice. We've got many which are statutory mandatory services for public health across the country. That is one of them. We have to use that measurement. We have to procure it from our community children's health services, and we have no choice, I'm afraid, on that. I wouldn't like to comment, actually, because I probably haven't read the evidence, but that is it, and that's what we've got to do. And it's interesting, that is one of 6. The others are things like, for instance, are 0 to 19 children's services, sexual health services. So it's a statutory service that the council have to commission.
No further comments. Anybody else? Go.
I think the obesity of kids is a really difficult landscape. We do have, somebody explained to me, we have a fat acceptance culture in our society now, body positivity, etc., etc. And a bit like smoking was acceptable, and it's taken decades to undo that acceptability. And I think we will get to a point where we have healthier communities and population, but I think it's going to take decades. And actually, ultimately, you can encourage kids to exercise as good as they can, but when they're being fed 80% ultra-processed foods, you might as well not even bother, because that's what's making our kids really unhealthy. But like you say, it's a national thing, it's profit over health, etc. That's a whole other conversation. Thank you.
Thank you very much. Agenda item 7, adult social care update. Andy, would you like to join us?
Thank you, Chair. I always have to reflect. How do you follow Helen, really? You can't. So I won't attempt to. My name's Andy Biddle. I'm the Director of Adult Social Care at Portsmouth City Council. The report's in front of you, just a few notes. Firstly, I think something I always try to do is give thanks to my colleagues who contributed to the report. It's an effort to pull it together, and particularly to Debbie Young and Katie Downer for the collation, drafting and formatting. I'm very grateful to them. So this is the 6 monthly update on adult social care activity in Portsmouth for noting. As discussed in previous scrutiny panels, the report aims to balance a focus on activities and outcomes with examples that show the impact of work for our residents. It's a long report, but most of it is in appendices. So what we've tried to do is limit the bits, and we think you probably want to see, to the report, but there's a lot more detail in appendices. There's also a lot more examples of some of the impact of the work. There's a couple of great case studies in particular. So under section 4, we've outlined some of the national policy bits that have changed or have developed since we last spoke to you in October. The Casey review terms of reference have been announced for the Adult Social Care Review. We're expecting an interim report in 2026 and the full report in 2028. We've heard recently outside of the announcement of the TORs that the recommendations are likely to be phased over a 10-year period. It just feels like there's a lot of kicking stuff into the long grass, which is really difficult to manage. The last major adult social care intervention was 2014, which was the Care Act. And actually what the Care Act did was update the National Assistance Act of 1948, so we do seem to be playing a lot of catch-up. We do know there was an attempt to resurrect Part 2 of the Care Act a couple of years ago by the previous government, but that then fell away in terms of the funding. So the review, or the publicity for the review, has said that we will see some announcements in 2026, but what they are we don't know at the moment, so we'll wait to hear that. We've also referred in that section to some of the varied documents that we've published or we've got due for publication. These documents really aim to help our residents and other stakeholders understand how we work our future plans and how we use the budget in the city. They're written to be as accessible as possible. We know that people have very different interaction with the written word in Portsmouth, and so we're trying to make them accessible and make them easy to understand. So section 5 gives a summary of how the service works to realise our vision. We've got a very simple vision. I think it's something that most people would sign up to, and a very simple strategic aim and an improvement plan to go with that strategy. Section 7 gives a bit more detail around the delivery of that activity that's set out in our plan on the page in our improvement plan. So that includes strength-based practice, information and guidance, particularly important. We've heard this afternoon from our two residents who represented that information and guidance is really important, and knowing where to get it and where to find it. Assessment and review. For us, one of our primary duties is to carry out assessment of need and then to put together support plans. And so we're working to get the right framework, the right paperwork, the right outlook to be able to do that with people. Our learning and development activity, which is really important. We've seen a change lately in learning and development for adult social care coming from a city council corporate function into the service itself, and we've done a lot of work around that. Waiting list management, hugely important. Again, I'd refer back to our residents this afternoon who were talking about their experiences. We do run waiting lists in adult social care, and you'll find most local authorities do, but it's about how you try and manage them. The waiting well concept, which isn't a great term, but it does what it says on the tin, really. How do we keep in touch with people? How do we communicate? How do we then, if their needs become a greater priority, how do we react to that in a timely way? I was particularly pleased to hear the reflection about the occupational therapist coming out for one of those folk, but also noting that there was no one to say to her, this needs to happen. So we'll think about that from our carers service as well. Engagement and co-production. We can't always co-produce what we do, but we can at least engage, so we've got the response from our residents, the view from our residents and how our services work. Communication, key to everything. Reablement, something we do well in Portsmouth, but we need to get better at. So that's enabling people to get back to a level of functioning or be as independent as they can, and there's a range of ways that we do that, and it's really important. It links to some of the public health agenda that Helen was describing as well, trying to intervene ahead of time, prevent, reduce and delay. We've got work to do, and we are actively working on our commissioning, so thinking not only about the services that people use now, but the services that people will need in 5, 10, 15, 20, 25 years' time. That also speaks to that growth in dementia that we've already talked about here today, and how we ensure that we've got the right response for when we see greater numbers, I guess. And that's a bit of a simplistic, but I think a helpful way of putting commissioning. Thinking far ahead of time so that you are trying to meet the right level of needs, but also at the right cost, and manage your budgets to do that, to try and combine those two things. We've included an excerpt there about workforce planning. We have a workforce that is of a certain age, and I count myself in that category as well, and we need to be thinking about the skills that we need in the future, but also how we encourage people to come and work in adult social care, not only in the council, but in the local area. And we mentioned in the national updates that we've seen a national campaign around work for social care. We've also heard quite a lot lately about immigration and migration. And we did have and still have a reasonable dependence or relative dependence on people coming to work from overseas in social care. We've stopped that route, but we haven't yet put something in its place. So there's a bit of an interregnum there which is difficult to manage. What we do have is an agreement that I think it's until 2028 we're seeing a phase, if you like, so that people who are already in this country working who came from overseas can continue to work in this country. And we've got various arrangements within the South East that if workers lose their sponsorship with an agency, we can try and help put them in touch with another agency so we can keep that skilled work within our communities. Because as you know, we have as most people know, we've got a lot of vacancies in social care nationally. I mean, it was in the nature of 150,000 at the last report. We've talked about digital, because everyone talks about digital. What we mean with that, there's two aspects to digital for adult social care. The first is what we have on our website, for example, how easy it is to navigate to find information if you are digitally enabled. The second is those aids and adaptations that we can help people have in their own homes. For example, if we think someone's particularly at risk and they might be heading for a residential care home because of their needs, we can put digital monitoring in to say, well, actually, they are getting up, they are making themselves a cup of tea, they are using their facilities, so maybe we don't need to react in that way. That's quite a simple example, but it's quite powerful. We can help someone maintain independence and put the right level of care in their homes. Financial management, it's been commented a couple of times today, we're probably not going to see a great deal more money for adult social care. And so managing within our budget and commissioning is part of that, commissioning services that will meet the need but at a lower cost is really important to do. A brief example of financial management, in Portsmouth we're blessed with a really positive relationship with our housing, neighbourhood and buildings department. And so we can build for our residents, for example, with a learning disability, so that we're not using care homes, we're using something called supported living, which is more personal in meeting people's needs, but it's cheaper in meeting people's needs. So that's one of our balances with financial management. And then finally, under Section 7, we've talked about our carers. I probably can't improve on what we've heard from two of our carers here this afternoon. They are the secret army, if you like. If we didn't have our carers, neither the adult social care system nor the NHS would be able to function. So it really is a matter of support them. But if you don't support them, it's at our peril, really. In Section 8, we've talked about one of the major projects coming up for ASC in the city, which is procuring and implementing a Care Act compliant case management system. Sounds relatively easy. It's an incredibly involved and detailed exercise that takes virtually all of your staff to be able to get right. So we don't underestimate that, and we'll be doing that over the next couple of years. Section 9 sets out our arrangements for the governance of adult social care in Portsmouth. External to the service through the Care Quality Commission process, internally through our quality assurance framework, and our monthly governance and improvements boards, and through the scrutiny of elected members, which is obviously what this forum is. Section 10 details some of the challenges and risks for adult social care, and Section 11 sets out the current focus, as we envisage it at the moment, for the next report to this panel, and then we have a list of appendices. So that's a brief run through of the report. Of course, happy to take questions, comments.
Thank you for that. Over to the floor if anybody has any questions. I just wanted to highlight that I think it's really forward thinking in some of the strategies that you're doing about the engagement with stakeholders, but also with regards to the staff. I do think that is really important, and yeah, well done for that. Thank you. Anything else? Oh.
It may be in the report, but you're right, it is a big report. So in Hampshire, 30 people, 30 residents run out of their own funding and have to be looked after by HCC. What are the numbers for Portsmouth?
We don't actually record those numbers in a way that we can just grab them up. So we see people episodically, and one of the reasons we're procuring a new case management system is our current system won't help us do that. So we have to do a dive for that. We won't see the same numbers as Hampshire because of the geographical spread and the size. And we also know, and it's been referred to today, the levels of deprivation in Portsmouth. We won't see as many self-funders, is the jargon, as they do in Hampshire. But we do have some. So what we've been trying to do over the last 12 months or so, is talk to our care home providers, most of whom are in the independent sector, similarly to Hampshire, and give them some information. So if somebody is living in the care home but is paying for themselves, we're helping the provider to help them understand when they need to contact us. Because what we don't want to happen is for people to contact us late when they've run out of cash. When they could have contacted us earlier, we could have given them information, advice, that sort of thing. We also do sometimes come up against a scenario where somebody who has paid for themselves in a care home, we wouldn't consider has that level of need, and we would consider we could support independently in the community. That can be really difficult for people because you're talking about whether they need to move out of that care home and live somewhere independently. That's handled, in my view and in my experience, with supply and receipt support, but that can be a difficult discussion. So we do have some, it's not as many as Hampshire, and we try to put as many procedures in place as we can so that people have the right level of information if they come to that time.
Oh, yeah, Matt.
Hi, Andy. We heard earlier about the loss of the 2 nurses and the impact that it can have. How are you addressing the challenge of keeping care workers amid rising operational costs?
Yeah, that's a difficult one. What we do when we talk about increases every year, obviously cost of living increases, that kind of thing, we try to have as much engagement as possible with our colleagues in the sector, both from a domiciliary care perspective and a care home perspective. And so we're discussing with them the rises in costs that they're seeing, the reason for those costs, and what we think is reasonable. And so we try and peg our inflationary increases each year to what we think is happening in the market and what's going on for them. Now, I can't say we always get that right, and some of our colleagues in the independent sector would say we don't give them enough money. That's a sort of a permanent state of affairs. But we try and be transparent in what we're doing, and we try and give them a very clear reason and a clear rationale for that. The feedback that we get from a lot of our providers, whilst they don't necessarily agree with the decisions we make about money, because of course we've got our budgets too, is that they appreciate the way that we engage and that they can have a conversation. We have, for example, we have monthly forums with all of our providers in their particular sectors, where you've got officers from the council, usually colleagues from finance in the council and the providers, and trying to work through some of the challenges and issues they've got. We connect them to training and development, just thinking about retaining people in the sector. So we have an offer whereby we provide reasonably low cost to them training. They come into the council, we provide training for them, for their staff. When we're talking to our regional bodies and working on issues in the sector, for instance, overseas workers that don't have certificates of sponsorship anymore, we're working with the sector and involving them in those conversations. We're inviting them into some of our boards and some of our forums, so we're hearing the voice of our providers as well as the voice of our residents. The recruitment and retention thing in social care is tough. Most people are paid either minimum wage or just above, and travel costs are a matter of dispute in a lot of places. If you're a first-line supervisor, so you're not necessarily working directly as a carer, but you're one above doing some supervision, the minimum wage pushes into the disparity between your wage and that of a carer. So keeping first-line supervisors is very difficult. Government has said to us that they want to see a wage for carers that isn't just the minimum wage, but actually acknowledges the fact that we need to recruit and we need to retain the workforce. I believe that's true. I believe that's an intention, but that's going to cost money, and local authorities are wary that they won't be fully funded with that money. Ultimately, it's not all about the money, but if you're paying your mortgage and you're paying your rent and you're putting food on the table, which we all are, of course it's about the money. So we can do quite a lot, but it still comes down to that block that we can't quite resolve around the cash, I think, is the honest answer.
It's a sad state of affairs. Thank you. Any other questions? Oh, Susie.
I haven't got a question. I just want to say, well, first of all, say thank you for the report. It was really well put together and gave a really good overview. But I suppose I just want to make a comment about some of the things you've been talking about. I think it's a bit of a hot mess, really, because all this stuff's been kicked into the long grass. Numbers are rising. There's no more money. Back to my thing about holistic and fragmentation, as a person who's getting older or a carer for that person, it is really scary. And I actually, whilst I think there's some really good examples of what what we do in Portsmouth here around filling in that gap, with the stuff you've just outlined there around carers, I just can't see a resolution on this. I can only see, I'd hate to be pessimistic because I'm quite an optimistic person normally, but I can't see, unless something significant happens in terms of primary care and social care, I cannot see this working its way through, which is really sad.
Thank you, Andy.
I told you I couldn't follow Helen.
Thank you for that. Welcome to stay, of course. Agenda item 8. Bernie, would you like to come and join us? Oh. Helen's back as well. No?
If there's anything worse than following Helen, it's following Andy and Helen. But fortunately, it's always a real privilege to report on the Health and Care Partnership
Brilliant.
in Portsmouth. If
Thank
that's
you.
all right, Chair.
Yep, take it that we've read it. Any highlights, summary, anything that's changed? Thank you.
I think really the reflection is how this work all pulls together the conversations that we've had throughout this agenda today. The Health and Care Partnership is brought together to bring all the providers together to meet the aims of the city under the Health and Wellbeing Board's direction. We last came to members in September with an update on the plan for 24-25. This is the refresh and letting you know where we are with that. We continue to work under the 5 pillars, the 5 priority areas, which are how we talk about improving the health outcomes for the residents of the city and how we meet those best in very tight constraints. I think it's really important then to really celebrate the successes of the case studies that we've published against each of the pillars, because I think that talks to all of the services and the ways of working that we've had today. And a real example of that is, I've literally just come out of the meeting where all the operational guys who are responsible for delivering these services meet at lunchtime once a month to talk through how they come together. So a real way of breaking down those silos is that we sit and talk through, I'm working on this, I'm doing that, how can we do that together? And that's across the organisation, so that's really important. And then, as I said, the plan is then pulling out together the strategic priorities that we're all looking at this year and how we continue to align those. Themes don't ever really change in terms of continuing to work for the good of the city across everybody. We do have real focus on frailty. That's an NHS term. We call it ageing well, staying well. Outside of that, and that's the language we try to work to. We are working really strongly to address some of the health improvement engagement work. You've seen the success that we've got there, and we do see the HDRC to really strengthen the community approach. Some big wins for us are our Better Care Fund integration, which is our pooled budgets with adult social care, and that stems right across into the work that Wendy will talk about in terms of the provision of our beds and our intermediate care through with the trust. So, all of that is, this report is about alignment and integration, and it's something we're very proud of.
Yeah. The only thing I would add, I want to thank Bernie because it has been, and I want to say, and I've said this before, I've been in Portsmouth 5 years. I've worked in the NHS most of my career and in local government and across many parts of London and the South East. I have never seen the partnership working that happens in Portsmouth. And I know we all say it, and it was also said in the other areas of work, but I've never actually really felt it. And Bernie has been working with Andy, Sarah, myself. We've been working with, obviously, the ICB, and all of the providers. And it's not been an easy time over the last couple of years, but we've really managed to continue, which is the important thing, because it's about relationships. We've managed to continue to keep those strong relationships and get through the difficult conversations and the difficult decisions to keep delivering, I think, for residents in Portsmouth. And I've never seen that anywhere else I've worked. That's all I wanted to say.
Thank you very much. And I think I need to echo that, Bernie. It's a fantastic report. And I think the person-centred approach is, you know, apparent all the way through. And I think, yes, we do work a lot better when we work together. And that is something that you do very well. My history was over at Southampton General Hospital. Something I think they could have learned is a lot from you, Bernie. So yeah, great report. Over to the floor. Any questions or comments to boost her ego anymore? She's blushing. No? All good then. Look at that. Check that one out. Thank you very, very much. Stay where you are though, of course, Bernie. And if we will now go on to agenda item 9. Yeah, we are. And we'll welcome, full squad. So again, take it that we've read them, read the reports. So just summarise and any highlights that you think.
So thank you, Chair. I'll introduce my colleagues from our medicines optimisation and pharmacy teams, get my teeth back in after that moment, who will deliver some of the update later on in the paper. As the paper sets out, there continues to be a lot of change in the NHS. We are working really hard as a system to focus on the needs of our patients and not let the dynamic and the politics that's going on around us impact on how we're delivering. I think that's really key to stress that we are a health system and we're working together for that. And it was nice to hear Jodie talk about how we're working with PHU, who aren't here today because their update was last time. And we're continuing to work under changing guidance. Since the paper was delivered to you last week, we received our updated guidance for 25-26 winter. That came out last Thursday. And we're working to turn around those reports. But it won't be a surprise to you that it's all about continuing to work together to get access to treatment for our patients as soon as we can, collectively across the board. So just bear with me whilst I get my paper up, because you finished the last paper too quickly for me to get to my notes. I'm sorry. So as an NHS Hampshire and Isle of Wight, we've just talked about our priorities again, which are refreshed in the plan, which is all about access. You've heard about how we're really trying to level up and understand how we're working it without destabilising. We do have a good news story in terms of our funding for the hospices. So that's an NHS Hampshire and Isle of Wight decision to put our hospices onto contracts, which means they have a known day rate for the services for the patients that are at the end of their life, that we can respond to them quicker. It means they can plan quicker. In the city, that does mean our Rowan's Hospice is going to receive more money from NHS Hampshire and Isle of Wight, and I think that's important to reference that at this point in the conversation. We've brought again the primary care access paper information, which we may get to talk about in some depth on page 247. That is an updated table with an explanation behind it. It is a calculation of the rate of access per 1,000 people on the list. So you can see comparatively how many appointments per 1,000 are on the list. It does exclude some of the partnerships in Gosport who don't submit their information. It's the best rate that we can give you. Just to update, we had NHSE visit one of our practices yesterday. Really good feedback from them in terms of their way of working in the city. So despite all of the conversations that we have about not having the right number of GPs, and we would obviously love more, we're getting very favourable feedback. And the last update that I had that I wanted to mention, which was dental, in that, as you know, we have been working with the university to increase the School of Dentistry. We are down to just waiting now to hear from the Privy Council as to whether they will approve the increase. So we got through the professional bodies approval, which was a huge step for us to get over. So that's good news. And I hand over to Neil and colleagues to talk to the concordance paper, if that's okay, Chair. Thank you.
Brilliant. Thank you very much. So I'm Neil Hardy. I'm Chief Pharmacist for the ICB. I'll let them introduce themselves, but you'll have to do the microphone. So.
Hi, I'm Jo Williams. I'm Transformation Lead Pharmacist for the ICB.
And I'm Phil Foster, Locality Lead for Portsmouth.
Brilliant, thank you. So if I sort of introduce the paper, just summarise, and I'll look to Jo and Phil, particularly around the detail. Actually, just before I start, I was just reflecting on the whole agenda. Medicines are the most frequently administered, supplied thing we do in the NHS, and obviously some of your previous agenda items, dementia, we've got a really interesting pipeline of medicines coming along that hopefully actually are disease modifying for Alzheimer's and dementia. Naloxone was mentioned by Helen, really exciting, ambulance, but also emergency departments are now giving it out. Smoking, there's a pharmacological element to smoking. Weight management, you can't have not seen in the newspapers about the injections, but that needs to be seen as part of a much bigger package. As my public health colleagues would say, social care, lots of the patients in social care are on medicines, and of course hospices. So it's interesting to see how medicines are everywhere. Anyway, to the case in point. So Medicines Concordance Service, you've got the paper. There's two services that are sort of different but linked. One is from Hampshire and Isle of Wight Healthcare, which is around a medicines at home service, and that's pharmacists and pharmacy technicians supporting patients, particularly those that discharge, but also referrals from GPs and other people. And then that links to the community pharmacy local commission service, which is around making adjustments to the patient's medicines. And I think often that is a multi-compartment compliance aid, so a box with the medicines in. But it actually, we should see broader than that and more holistically than that. So the ICB proposes to decommission both services, but really importantly, and this came out on the executive committee discussion, making sure that we've got mitigations in place, particularly for existing patients. So there is a significant number of patients currently receiving MCAs, and clearly we're not going to do anything that destabilises those patients. So they will continue until there's a clinical decision that actually there is an alternative. I did write on the top of my briefing, communications plus, because I think it's really important that in this journey, and it is, we're sort of at the start of the journey, aren't we, Jo, even though that we actually talk to adult social care, we talk to the community pharmacists and their representatives, and we definitely are already talking to Hampshire and Isle of Wight Healthcare and the chief pharmacist around their team, and how we can work with them to focus it more. It's probably worth saying a little bit around what's changed in the last 20 years around these devices. And they were seen very much as a sort of probably the only thing that we had available. But I think the big change in the last 5 years has been the PCNs are now funded to employ community clinical pharmacists. And their main role is to do around doing structured medication reviews, which seems like a fancy way of saying helping patients with their medicines. So it can go from telling the patient to bring all their medicines in, and we'll go through them, including their over-the-counter medicines. And of course, there are opportunities to stop some of those medicines. And that's not about money. That's about actually your risks and benefits change over time. And they might have been sensible 30 years ago to when you started that. So I think actually one of the reasons, one of the big mitigations around this is the fact that actually there is now a group of professionals that people can be referred to that their job is literally to work with patients. Some of that's deprescribing, some of it might be simplifications of regimens. Actually, is there a combination product that actually means you're only taking one medicine rather than two? And it also is working with the community pharmacist around other things. I mean, often a side of A4 with the words written in big enough font that patients can read them is the answer, whereas we aren't very good as a profession of producing anything other than a tiny label that I can't read. Yeah. There are some, I think the other thing just to raise from the paper is the fact that despite MCAs being in place for a long while, there's no convincing evidence from a sort of clinical trial level that they actually improve adherence and they're safer. And in fact, there are quite a lot of studies, aren't there, Joe, around the fact that unless they're considered carefully, they can actually be harmful. And certainly people with dementia, it's certainly often not the solution because the patient is still confused. Finally, I think I'll probably finish and hand over to my colleagues. Within the national community pharmacy contract, there is a requirement for the pharmacist to work with the patient or their carer to make reasonable adjustments. So there's no specific funding for MCAs, but there is a recognition under the Disability Discrimination Act? Equality Act, thank you. That assessment should be made. And one of those solutions might be an MCA. So that is actually allows patients who do meet those criteria to have an MCA, but it might be other things such as large print labels or a sheet of A4. Would you like to add anything, either of you?
I think we've covered it.
No. So, happy to take questions, of course.
Yes, thank you very much for that and for that add-on. Any questions from the floor? No. Oh, no. There we go, Susie. Go on.
It's just that the changes that sometimes happen within a GP surgery, for example, like having the pharmacist there, it's very interesting being on the receiving end of it when you actually don't know what's going on. And so I think there's something to be said around the communication of these changes. And actually most people are quite capable of understanding why something might happen. But genuinely, I think going to a doctor's now is you're navigating a landscape which you don't understand. Now, I am absolutely all for not having the only route to getting to speak to someone being an appointment with a GP. I get that. But when sometimes you're told things or suggested, or why didn't you do that, or you have to access it like this, you haven't got a clue what's going on, particularly if you're fortunate enough to have not had long-term health issues. I think people who were in the system were kind of there when I liken it to when everything went cloud technology. If you weren't in it at the time, you haven't got a clue what's going on. And it's a similar thing. So coming back to it, it's like there's no reference points. And then there's a whole social anxiety about actually not getting that when you're feeling ill.
Yeah, and it's interesting. Tom, who sat behind me, is our comms lead. If you recall, in Portsmouth, we ran that campaign as we were coming out of COVID around it takes a team to treat people, to try and explain. And it was on buses and it was on hoardings. Now, that's been widened out across Hampshire and Isle of Wight in totality as a campaign that we're using. And I think it's something we need to keep doing, to keep engaging with people where they are. And that's a huge part of the work we do in Portsmouth through our community asset work. Not instructing someone to come to an institution, but to come to talk to us. We go and talk to people where they are. And there's huge examples of work that we do through Health and Care Portsmouth. The Hive have just won some work on some funding for digital exclusion to go and, to work through those kind of things. So I think we're getting better at it, and it's an onward journey, but we're actually doing a lot of work ahead of other people, and we just need to keep at it.
No, absolutely agree. And we have one of our main roles as a team in the ICB is to support the PCN pharmacy professionals, and actually exactly what you've said. So we have meetings with them, don't we? As well as they're part of our weekly team update. But actually, there's a really good point there to actually get them thinking about how they introduce themselves to patients, why they're there, which bit they're not going to do. Because no, you're absolutely right. And of course, hospitals are very similar now because everybody wears scrubs, so you've no idea when you get on the ward who you're speaking to. But no, we'll take that as an action that actually will get the pharmacists and the pharmacy technicians thinking about how they make it clearer to patients when they invite them and when they introduce themselves. Thank you.
Oh, sorry, just to add to that, we've worked with the Health Innovation Network to produce some patient resources. So patients who are being invited for medication reviews will receive that before the appointment to prepare them, so they get an idea of kind of what the reason of the appointment is, kind of think of some questions beforehand, so hopefully that will also benefit.
Thank you very much. Thank you. You're free to go. Item 10, Wendy. First one here, last one to speak. Bless you. Thank you very much. Take it that we've read your report and then just summarise and add any additions. Thank you.
Thank you so much. I've got to follow everybody today, so but I'm also the new person here, so I really great to meet you and meet so many people in one place, which is great. So I'm Wendy Rees, and I'm the Managing Director for the newly formed Hampshire and Isle of Wight Healthcare. So I actually lead the services for community health across South East Hampshire and Portsmouth City. I recently was the director in South West and Southampton City, so I've had a number of years of working in a city environment as much as a part of Hampshire environment, so which I think has been really helpful as I start my new role. So I'm getting to know my colleagues, and thank you so much for inviting me today. So my paper really was just a bit of an update, just to sort of say the restructure for this division, or for the trust as a whole, but for this division has completed. I am the operational lead for the division and the services within the ones that we deliver as a trust, and have a new team of people. Some of them are people so Joe Pinhorn, Andrea Havey, Simon Nightingale, so people that have been working in the area for some time, so we're not all new. I'm obviously getting to know my colleagues at the council, like Andy as well. So this paper just wanted to talk to you about a couple of changes as we bring teams together, and as we start to work a little bit more around our resilience and sustainability, and starting to think about what are the needs of the population now. We recognise that we have some really good integrated services in the city, one of them being that sort of reablement, home-based rehabilitation support. But actually we're in a really good point now to start scaling that up. We know that patients do better. We know people do better. You can tell I'm NHS and a nurse. People do better when they've had an illness or an injury going home straight away. And what we want to do is to strengthen that pathway. I was a community nurse in the 90s, so when I was a community nurse, we didn't have anybody around us, it was just us. But now we have, really highly skilled therapists, really highly skilled practitioners, nurses that prescribe, geriatricians. So we've got a really strong community offer, so that actually people, when they do go straight home after having a spell in Queen Alexandra, they can actually go home with a really good network of people. We've got around 140 inpatient rehab beds in this area, 56 in the city, which is actually quite high. And I think as we start to think about where would money be best spent, I've started to, as you'll see in the paper, think about maybe reducing our beds a little and moving the staff and the skills into the community, which I've started to do alongside Andy at Summerlee. The second part of the paper, just talking a little bit about community nursing, passionate community nurse myself. Across South East Hampshire and the city, we've got a 24-hour community nursing service, which has been here for a number of years. That's not the model across the rest of Hampshire. We find that actually that's quite a difficult model to deliver, requires, a lot of staff, a lot of shifts, and actually cause a little bit of silo working. So our proposal very much is we'll go to an 8-to-8 model, which is the same across Hampshire, allows us to do 2 shifts really, brings the staff into that core time where patients actually probably better for them to receive care from us, and then the sort of the 12-hour out of hours delivered by our GP out of hours service, which is currently PHL, who then provide the nursing element. At the moment, it's really quite it's lots of bits and pieces, and it sort of maybe not working for patients. So we're proposing that change as well. Thank you.
Thank you for that, Wendy. Any questions from the floor? No. There we go. Thank you very much for your report. We look forward to seeing you in November with an update.
Thank you.
Hold on.
I know you're talking about removing the step-down beds. Have you at the moment got sufficient for people coming out of hospital or people stuck in hospital waiting for those beds? Does that make sense?
So one of the reasons we decided to make this change was that we're finding that we are filling our inpatient beds with people that actually could have gone home. So actually we've got people that we're using the beds because it seems to be the quickest option, when actually we've got really good community teams. So we're using a quick option, which is a bed to a bed. People might stay 2 or 3 days, and actually that's really quite disruptive for somebody. So actually we don't have the demand for the number of beds that we've currently got. We do have adequate staffing and resources in the community. So we've reduced our beds at Summerlee by 10 at the moment, and actually we've got about 5 or 6 additional staff in the community ready. So we haven't seen a drop in terms of our transfers out of the hospital, and we haven't seen any delays. We're doing the sort of 10 reduction as a trial for a month. We're going to evaluate that really closely to see what would be the next step. If I'm really honest with you, we're looking at to reduce about 40 to take our bed numbers down to around 98, which is in line with the other parts of Hampshire and Southampton. So we've got a lot of beds, quite an expensive resource, and actually I don't know if it actually improves people's recovery. It gives them another stage, and sometimes can actually make people with cognitive sort of concerns a little bit worse. So I think we really want to sort of have a real hit at it this year. We can move, we're not going to lose any staff, I guarantee you. The staff will move into the community.
Is there the pressure then from the hospital to get that person out of the bed, and it was the obvious option to move them to another bed? But you're saying it doesn't actually, because it would take longer, are you saying it doesn't take longer to put them into the community? Have you changed the process? Does that make sense?
Yeah, the pathways are a little bit confused, and that's one of the reasons why it's really nice to bring the whole division together and make the pathways really simple, because obviously we've got 2 county councils, so just the pathways are a little bit different. I mean, luckily we manage the Transfer Care Hub alongside our local authority partners, so we can streamline the pathways as well. So at the moment, often when maybe you haven't thoroughly assessed somebody, moving them to a bed is often quite an easy thing to do at a time of pressure. Whereas actually, it doesn't take much longer. If we actually look at home-based options first, it doesn't take any longer to do that. The teams are there, but sometimes we go for the safe option, and often people are a bit worried about what happens overnight and what happens if the person falls, and there's lots of barriers to it. But actually, there's evidence to say that the person will be better and more independent at home.
No, I totally agree with what you're saying there. I think it's fantastic, actually. Yeah, it can just prevent people from actually wanting to go home if they're being told by somebody that they class as professional and knows best. No, you can't go home just yet. You need to go into another bed, and they kind of start to question themselves. Yes. Yeah. Yeah.
Yeah, I mean, deconditioning, both physically and cognitively, is a massive, massive concern for us, because we know for long-term needs and for long-term care needs, it's really difficult. And the quicker you can get somebody, it back in their home, making cups of tea and in their garden with their family and friends, we know that makes a difference long-term. Yeah. And also the push from the hospital, in a way, is good, because actually they don't want to keep people too long either. So actually, we want to, respond very quickly, and the team are absolutely brilliant. I mean, the city team is integrated with Portsmouth City Council, and it's absolutely fantastic. The Hampshire team, it's not integrated, but what we can do is learn from the integrated team. But we've got new staff starting. We've got really good ward staff that we can easily work in people's homes, and I think it's just a really good opportunity for us to do that.
How are you going to do the selection process of which nurses go, which medical teams, go to the community?
So we're going to do consultations. So we're going to sort of consult with all the staff across the 138 beds and say, we're redesigning it, better for patients. And then what we'll do then is sort of do that sort of almost one-to-one sort of skill matching, and just sort of say there are these opportunities for you, probably around, if I'm honest, for 40 beds, probably around 30 people may need to move their roles.
Yeah.
But also we found that when we've spoken to staff about it, we've got staff in the community teams that are saying, do you know what, I'd like to work in the wards. So actually we've had a
Could
lot
be a
of
swap.
staff saying actually we could have a real mix around now. So
And that's nice
great.
to have them involved as well, because that's
Yeah.
going to keep your staff retention as well.
Yes,
so.
and we know that staff that work at Summerley and in the city, some don't drive, and then we do know that it makes people really anxious about sort of jobs that they might have to then get to by public transport. But I think we've got a number of, if we look at St James's, Orchards and Limes, we've got a number of city-based, even inpatient units that people can move to. So we're not saying you have to move from here to here. We're saying across the whole division now there are so many new opportunities for you.
Yeah, amazing. Any further comments from anybody? No? Thank you, Wendy. Thank you very much. So thank you, members. That is all on the agenda today, unless I've missed anything. No. So the next meeting is Wednesday, 17th of September, and I want to thank you all for coming, and I officially close this meeting at 3:15, and we're going to stop the live stream. Thank you.